What's that? Okay. So we're going to get started. I know there are a couple of people I think who are going to trickle back in. I wanted to just mention, so we do have some folks who are joining via web. So we'll probably take some time during and at the end of the panel to make sure that we take any questions from folks on the web too. But I just wanted you all to know that we do have web participants. So it's actually a larger group than what you see in this room. And I wanted to, I don't remember if you said this at the beginning, Corey Robinson sends her regrets about not being able to be here. Corey Robinson has been facilitating the CANDO process from the JFK Partners end of things for since the beginning of its existence, and she unfortunately wasn't able to be here and sends her regrets. I'm not sure if she's on via web, but just wanted to make sure folks knew that she's sending her regards and regrets. So I think what we just heard from Louisa is a really good segue into this panel. So there are a lot of things we need to think about, and I want to give a little bit of introduction to both the panelists and the topic of the panel. But first, sort of thinking about what can we do with the information that we just heard about what's going on with the crisis pilot, and what Carol brought up around what do we do with that? How do we make sure that there's and Brian asked the question about sustainability, how do we make sure that we can sustain that? So if you all could be thinking about the sustainability of the crisis pilots as we go into this IDD and mental health workforce and systems discussion, I think that would be helpful. So I'm Sarah Davidon, and I'm faculty here at JFK Partners at the University of Colorado School of Medicine. I'm in the Department of Pediatrics, and I was also one of the folks who was working on the gap analysis that hopefully, if you haven't seen it, you have a chance to go to the website that was up here, and we can put it back up at some point if people didn't catch it. But if you go to our JFK Partners website and search for gap analysis, you can also find it. So was it only 5.5 years ago when that started? So I think...
I mean, it kind of started with the Colorado Autism Commission, which was 10 years ago.
Well, yeah, so the gap analysis...
But the gaps analysis, I remember because I just turned 65 and it was on my 60th birthday.
Good.
Val and Harry and I were at that conference. And we were going, this is what we need.
So as Carol said, we did focus groups around the state. We went to sort of really try and figure out what was currently going on, how needs were being met. But I also need to say that, when I moved to Colorado in 1998, one of the first committees that I participated in when I started working for the Colorado Department of Human Services was a co-occurring DD mental health initiative. So what do we do? How do we best serve the population? So that was now 20 years ago, and we're still having this conversation. So we wanted to pull this panel together to really get specific and articulate what do we need to do next. We are at a place where we can't just say somebody else is going to take care of this, or make an assumption that one system is going to fix it, another system other than the system in which so we're working. We can't do that anymore. We have to figure this out. So we're hoping that this panel can light a little bit more fire to that discussion. So the panelists we have today represent a variety of perspectives on workforce and systems issues around comprehensive, accessible, appropriate mental health care for individuals with intellectual and developmental disabilities. And I wanted to go through just a little bit of information to set the stage for this, because I'm not quite sure sort of where, I wanted to kind of level the playing field about some of the information that we have and kind of what we need to think about in terms of the service delivery system and access to supports. So there are estimates that the rate of mental health conditions for people with IDD is about 3 times higher than for the general population. But what's important to note is that estimates of co-occurring IDD and mental health range from about 14% up to about 75%. So something to think about with that variation in percentages is that those rates might be due, among other things, to a lack of consistency in how assessment sort of methods are working and how we're assessing the population of people with IDD and mental health needs, but also with diagnostic definitions. So unfortunately, treatment practices still have to catch up with the reality that people with IDD actually do live with mental health conditions. And we really need to think about it as a sort of an equal access issue. So if somebody who perhaps doesn't have an intellectual or developmental disability needs mental health services, there's a somewhat clear system of how that person accesses services. Yet we have a population that where it's a very complicated and confusing system. Sometimes and even when there is treatment, sometimes that treatment is provided differently because of an intellectual or developmental disability. And one of the concerns there is often the sort of challenging behaviors that might be seen, or sort of what perhaps could be a mental health issue is attributed to disability and not looked at as a mental health issue. And so then the treatment ends up looking different. So we're going to talk a little bit about that. So although mental health centers and local community-centered boards, so we heard about sort of both of those are in partnership with the crisis pilots that we've got going on in Larimer and out in Grand Junction. So although there's a geographic overlap around the state in the community-centered board system and our mental health system, we still have very kind of different mechanisms for access in those two systems. And it makes it very difficult for individuals with IDD to access mental health services. So our panel today is to really sort of dig into some of the workforce and systems issues that are still making that a challenge. So I want to introduce our panelists, and they can give a little bit more about what they're doing and who they are and what they're doing. So we've got Carol Meredith with the ARC of Colorado, who's also a parent. We've got Brian Talent with Aurora Mental Health Center, and Ashley Brock-Baca with the Colorado Department of Human Services Office of Behavioral Health. So each panelist, if you could give a brief introduction of who you are, and then what I'm going to do is I've got three questions that I've prepared to ask the panel about some of these workforce and systems issues and sort of what can we do next. But then we're also going to make sure we open it up so that we can have some discussion, and if you all have some questions or comments that you'd like us to respond to, we'd save time to do that, and we'd be happy to do that. So Carol, can you just start with a quick introduction, and then we'll go down?
Hello. Now it works. Hi, Carol Meredith. I am the executive director for the ARC Arapahoe and Douglas counties, and I've been there for 20 years, starting in January, which is kind of amazing to me. But I started down this road as a parent. My son Alex, who is going to be 34 in May, was diagnosed as being on the autism spectrum when he was about 2.5. So really, I've been doing this work for 30 years. And the way I describe the work is I'm just trying to figure out how to play this game, right? I'm trying to figure out what the systems of care are out there, how to access them, who pays for what, and how to help other families. And that's how I got on the path. I was just trying to figure it out for me, and then it was kind of like, well, maybe I could figure this out for a lot of other people too. Might as well. I'm trying to figure it out for me. And ended up working in early childhood for about 4 years for kids with disabilities, and then came over to the ARC, and I've been doing it ever since. So the ARC does birth to death, all kinds of different disabilities. We don't care what your label is, you belong with us. We want you to be a part of who we are and what we do. But I've sort of specialized in this dual diagnosis, mental health, IDD, because it's a big problem. And I just wanted to say, just last night, I got a text from a mom who has a son, early 20s, has been in and out of crisis for the last 6 to 8 weeks. She knows how to play this game. She's a skilled person, but she's starting to wear out. He's requiring 2-on-1 right now within his residence. They called the crisis line, the Colorado crisis line. This is Arapahoe County, so I'm not talking, and I'm not talking Bennett Byers Strasburg. I'm talking like Centennial, like in the middle of the metro area. They said, "Oh no, sorry, we can't send anybody out if he's not suicidal, and if he's got those kinds of behaviors, you have to call the police." And she was so disappointed because it's not like she hadn't tried a whole bunch of stuff before she got there. So that's just one story. But I continue to get these kinds of advocacy cases more and more. And it's important that we figure it out.
Thanks, Karen.
My name is Brian Talent, Program Director at the Aurora Community Mental Health Center. I run the dual diagnosis programs for youth who have developmental disabilities as well as mental health issues at Aurora Mental Health called the Intercept Center. It's a collaborative program between Aurora Mental Health and the Aurora Public School District, where we have a small day treatment program. But primarily we serve the community with our outpatient program, where we serve youth between the ages of about 6 and 21 years old who have co-occurring disabilities. I started working with people with intellectual developmental disabilities about 26 years ago, working with adults as a behavioral specialist. And, when I came to Colorado and as I tried to find a job, people kept saying, well, they look at my background of working with people with developmental disabilities and said, Aurora Mental Health really needs you. And so I gave it a shot. I said, working at a community mental health center that serves this special population, this is really interesting and pretty exciting. 21 years later, last week I celebrated my 21-year anniversary at Aurora Mental Health. And along the way, I have always been involved in trying to help the state of Colorado really try and replicate what we were doing in Aurora, because it was very clear that the need was statewide. And I also sat on the board of directors for the National Association for Dual Diagnosis for about 8 years, because it's not just a problem that's unique to Colorado. This is a nationwide and actually an international issue, bridging the gap between services for people who have intellectual developmental disabilities and mental health.
Hi, I'm Ashley Brock-Baca. I work at the Office of Behavioral Health. And for the past 5 years, I've been working under the System of Care initiative in Colorado, which is trying to build a coordinated system of services for children that have mental health challenges who are system involved. And we focus on very intensive care coordination and peer support, so providing parents with lived experience to support other parents, as well as youth with lived experience to support other youth. And so our focus is on children birth through 21 to 25, somewhere in the early young adulthood phase. And I have recently taken on a role as the service array developer. So we have realized that in addition to sort of implementing these programs, we have to work to address the gaps in services, whether that's by providing training and technical assistance, or through other methods of actually trying to increase the number of providers in certain networks, accepting Medicaid, et cetera. So along with my team, I'm working on that System of Care initiative. And several years into my job in the System of Care, we noticed that even though the dual diagnosis, kids with IDD and mental health were not necessarily a target of the effort, we were really just broadly working with kids that had mental health challenges. We found that a number of our communities were serving this population who had particularly autism as the most common, but other IDD as well as mental health. And so then we started thinking about, what does that need to look like? And so we're actually just about to start a community of practice with some of our grantee communities who are focusing a portion of the families that they serve to be those who have a child with an IDD and a mental health issue. So even though I'm newer, much newer to the field than the other panelists, I'm very excited to start finding some solutions to the gaps that we have and the workforce knowledge and the skills to better serve this population. Thanks,
Ashley. And that's a great segue to the three questions that we're going to hear from the panelists on, because we really want this to be about finding solutions. I think many of us, if not all of us in this room, have heard about some of the problems. So we really want to start delving into, so what's next? So what do we do? How do we very clearly articulate what do we do next? So I want to start by asking you, Brian, what, if you could identify one or two of sort of the primary issues in services or workforce needs for people with IDD and mental health needs?
I think it's important to differentiate a little bit between what is good systemic preventative care and routine care for people who need services upon first contact, versus what I think we often end up dealing with, which we've heard quite a lot about today, which is things have gotten so bad to the point that it's a need for crisis services and for residential treatment. I think that there's kind of two issues. Those are two different workforces, I guess I would say. It's very clear that one of the, I'm kind of going to answer this question by working a little bit backwards, and because for many years I've been wondering. I know that one of the things that created the programs at the Aurora Mental Health Center when the state of Colorado first went to capitation was that we had a behavioral health organization that was made up by the providers. It was the only BHO in the state of Colorado that was set up by the providers, and I think that speaks a little bit to the fact that maybe that behavioral health organization was in tune with the needs of the community as opposed to really being interested in financial viability by cost shifting. I mean, that's the way that I've kind of looked at it. And so one of the things that I think has been really important to emphasize, because I asked the question, why haven't these types of programs been replicated in the state? Well, that's a very good question. When I ask myself that question, because I can say with confidence that our behavioral health organization, we did a study. We looked at what were the total inpatient days for youth with developmental disabilities prior to the creation of Intercept Center versus 3 years after Intercept Center. And we had an overall reduction of about 73% in the overall inpatient days. That's you can create a lot of services preventatively, outpatient and day treatment with the amount of money that was saved in that kind of a crisis emergency inpatient care where kids were just stuck in the hospital and I mean, before the creation of Intercept, there were a few youth that were in the hospital for over 200 days in the year and living in a hospital. So I've kind of gone beyond it's just the right thing to do. It's really the physically sound thing to do. And so why haven't the community mental health centers and the BHOs really worked to do what is physically responsible? And I think that there's a little bit that has to do with the culture of disability, unfortunately, that's a part of this. I've heard over and over that we don't have the right training to serve this population. But then my frustration also has been, well, the training has been available. Why hasn't anybody really wanted the training? Okay. And so I think that some of the significant changes that need to shift, one obviously has been that there has been a financial disincentive to serving the population. The reason I say is that it clearly is an intensive resources population. The therapy has to be concrete and very repetitious. We are an intensive services team at the Aurora Mental Health Center. And so I think that when you're faced with how do we develop this workforce and put the investment in to serve this population versus using the exclusionary diagnosis criteria to cost shift this population to the community-centered boards, which is another one of the things, we talk about diagnostic overshadowing. We talk about how there's an over-attribution of the symptomology to the developmental disability. Well, there's also an overshadowing in terms of where we think the resources should come from. So most mental health professionals don't understand that the community center boards don't have psychiatry. They don't have psychotherapists. They don't have a mental health service delivery system. So I think that education is a big part of it, but primarily I think that, and we have some opportunities, I believe, with it's hard to answer the question too when we don't really know yet what the impact is going to be from switching over from a behavioral health organization driven system to the regional accountability entities, which I think that,
and we will talk a little bit
we're going
about
to
that.
talk a little bit about that in a little bit. But one of the things that's happening is it's going to be shifting a little bit more to a fee-for-service type of system, which I think, although I have to say I'm not really sure if that's overall good for mental health in the state of Colorado, but for this population, I think that it changes, because instead of, you know, a system's given a behavioral health organization who's given a lump sum of money, and then you have to provide all the services underneath that umbrella. Now, if we're looking at a system where you just bill fee for service, serving more people and providing more services is beneficial. So overall, I think there has to be development of this specialization at the community mental health center level. And the reason I say that is because that's where the community interfaces to get mental health treatment. So I think that we're shifting to a system where, and I hope we can take advantage of the opportunities where basically the community mental health centers are financially incentivized to serve the population. I think that that's really important. I think that there are also possibilities for contractual requirements so that community mental health centers have specific, and if you break it down to brass tacks, really what it comes down to are community mental health centers having specific clinical staff that are specifically trained. It's like what we're seeing, you know, that was capable in the pilot program. It's something that we've done in Aurora somewhat more organically, but we recognize that having, I think it makes a lot more sense to have specialists that are specifically trained than it is. I've seen other community mental health centers where they said, we're going to take the entire mental health center and we're going to give them a basic training in intellectual and developmental disabilities, and we'll disperse that population throughout our clinical programs. And unfortunately, that doesn't work very well. I think that it's a much more better approach to have specialists. We have all kinds of other, I think that working with this population is a cultural competency in our field. And just like we have specialists, we have early childhood specialists, we have older adult specialists, we've got specialists for refugee populations, we've got specialists for all kinds of subpopulations within our community. And I think that this is just one. If we can do that with other specializations and other subpopulations for cultural competency, we can do it for this population as well.
That's great. And so, Carol, I want to ask if you have anything to add on to that. If you could identify sort of like a primary issue in what some of the workforce and systems challenges have been around serving the IDD and mental health population, what would you say that is? I know it's hard for you to pick one.
Well, it's partially just because I'm old, but I think the primary problem has been the way we develop the systems over time, and the silos of funding, and putting, you know, part of it into DHS and part of it into SAMHSA and part of it into the CCPs and part of it into ICFUP and part of it. I mean, I'm kind of an old rules for radicals girl. I mean, it's like follow the money. If you can follow the money, and I can't follow the money in the mental health system. I can't figure out where it goes or how it works. But, and it's not for lack of trying, but I think that's the biggest problem is that we have culturally divided ourselves in a way that is not inclusionary. And if the ARC is about anything, it's about inclusionary. So if we can say, yes, people with IDD do have mental health disorders. Yes, they should be included in the systems of care that provide those services. And yeah, they're going to cost more. They are. Let's just own up to it. And in some cases, they're going to cost a lot more, very expensive people, because they're very complicated, and it takes, you know, like if I go in and I have a bout of depression and I get 8 sessions of psychology and you know, some meds, I'm more than likely going to be okay. My son might take 3 to 5 years of weekly sessions before you get the repetition, you get the systemic stuff in place for him to be able to cope with that and actually recover from a mental health condition. So I mean, I'm with Brian. If we pay for it, if we figure out ways to pay for it, if we can simplify the access to the systems and then figure out a way to pay for it. I mean, 15 years ago when Betty and I said, well, we got to pass an autism waiver bill. And they all said, well, we can't do that because there's nobody that provides ABA in Colorado. And there were very few people. And we said, well, if we build it, they will come. And it's not build it, it's if we pay for it, they will come. Look, now we still don't have enough. Well, we got a lot more than we had before. So it's partially money, it's partially structure, it's partially culture.
Thanks.
I could just piggyback and just say, you know, but the thing is that we are paying for it. What was one of the things that came out of the regional center task force and the work on the regional center task force is that, you know, we identified that the amount of money that we're paying in inpatient care, or the amount of money that we're paying in first responders, when this group gets to that point where they're in crisis, they're spending that amount of time in the hospital, they're revolving door to the hospital, we're paying for fire, police, we're paying for sending kids out of state for treatment. We are paying for it. And if we can formalize a more preventative and a more responsive system, then we will ultimately save money. I think that's where my frustration has always been, is that, yeah, the way that we're doing it with cost shifting is more expensive. And it's also, I mean, it's traumatic.
Thank you for that addition. Yeah. I think that was an important addition. Let's, if you could hand that to Ashley. Brian had mentioned, you know, some changes coming with sort of how behavioral health services will be managed in our state. And so, Ashley, I wanted to ask you, with the changes that are going on with the Accountable Care Collaborative Phase 2, which is going to impact how Colorado is managing and delivering physical and mental health care, can you describe how this will impact mental health care, what people can expect, and also any other initiatives that are upcoming that could impact this population?
I'll give it a shot. So there are some changes coming up, and if you're not familiar, currently our behavioral health system is administered by the BHO's Behavioral Health Organization, separately from physical health care, which is managed by the RICOs. Under the new system that will start on July 1st, the behavioral health and physical health will be jointly administered through the regional accountable entities, or RAIs. And so there's a focus in the Accountable Care Collaborative Phase 2 on providing better care coordination and better management of chronic disease, which is one of the main drivers of cost. I think that they have some incentives to provide better care coordination generally for the entire population, and integrating physical health and behavioral health payer administration may at least provide more financial incentives for behavioral health services that reduce hospitalization and ER visits. So there is some potential incentivizing. And then there's also a bit of a shift towards more value-based purchasing, so that the RAIs have sort of benchmarks for demonstrating that they're basically, that individuals that they're serving are doing well, and there's a financial incentive, you know, for those doing well. So I think that it's certainly possible that we will see more emphasis on care coordination under the RAI system. There will remain some separate payment mechanisms for physical health and behavioral health. So physical health will remain something more fee-for-service, while most, but not all, behavioral health will remain under a capitated system, with the exception being kind of more intensive and expensive services being more like a fee-for-service system. However, behavior services for those with IDD and autism are not managed under the RAISE. Those are still carved out under some waivers. So for example, the pediatric behavior services that are now moving under EPSDT will remain separate and not managed by the RAISE. So I think I can't answer that question, but those services will remain. So I do think that there's some room for growth in further integrating those services and some waivers. And I think part of the reason is that there's a feeling that when there are these special populations that they need to do sort of a more specific set of services, and the pediatric behavioral services being under EPSDT is designed to increase access, so it's not included in that capitated system. So I think that is potentially good to keep that separate. However, all of those things can pose even more of a challenge towards care coordination. But I do think that generally we may hopefully see a shift towards more the RAISE being more incentivized to provide care coordination, whether that's with mental health or behavioral health and other systems, between mental health and physical health. So that's sort of the intent, is that there will be more care coordination and better accountability. So every individual who's receiving Medicaid will be automatically enrolled into the ACC Phase 2, meaning that there will be oversight of their health outcomes through the RAISE. So that may provide, again, more incentive to provide care coordination and to especially do anything that reduces emergency department visits.
Do you want to speak at all to how wraparound might fit, if for people who have higher level needs, might fit into the RAISE system? And
absolutely. So the past 5 years, I've been working to promote an intensive care coordination approach called high fidelity wraparound. And it's actually a more intensive approach than the START model. So the case ratio for each facilitator is only 8 to 10 families. And it's typically a much longer process. So it's not designed just as a crisis intervention, but rather as a way to increase families' natural supports and self-efficacy and get services put in place. And most families receive high fidelity wraparound for about 12 months on average. And so it's designed to be sort of a, not necessarily long-term, but a little bit more of an intensive, year-long process to really get families to a point that they aren't so dependent upon systems and crisis interventions. And it includes crisis prevention planning. And so we are hoping that there will be an option for the RAISE to use Medicaid to fund high fidelity wraparound more broadly. So currently it is an option. It's something that the BHOs can choose to pay for. And we're hoping to increase that with the RAISE and provide some sort of direction to utilize this type of approach for families that have really high complex needs. And it is designed to keep kids out of residential placement. So that's really the way that most states and localities that have used high fidelity wraparound have been able to save a lot of money, is by mostly avoiding residential placements and, of course, decreasing hospitalizations and other intensive services in favor of more community-based services and intensive care coordination. So that's what we're promoting, and it's too soon to say yet what exactly will happen, but we're hopeful that we will see an increase in this type of care coordination under the RAISE system.
is there anything that public input could do to help with or to help with the RAISE using, or that
so there have been
wraparound? Or
there have been a number of stakeholder meetings. And I think in the future, anytime that the RAISE have stakeholder meetings, it's really important that people show up and talk about the importance of these family-driven, community-based, processes and services like high fidelity wraparound and others that are similar, and really voice that this is the solution to, you know, our high rates of hospitalization and ER usage and crisis services and everything, is to get stable things in place with families, increase their natural supports long-term, give them access to family advocates and others who can, you know, maybe provide that long-term support. So anytime that there's a stakeholder meeting with the Rays, they are charged with building what they're calling a health neighborhood, more broadly than a health home, but a health neighborhood. And it is their responsibility to listen to the community and ensure that they're meeting the community's needs.
Great. Just earlier, and Ashley, you may be the best person to answer this, but I'll any of you. So Cristiano earlier, when he was doing the update, the legislative update and policy update, talked about the CHIRP waiver and also the Child Mental Health Treatment Act. And just wanted to know if you had anything to add about how those, what's happening with CHIRP and or the Child Mental Health Treatment Act might help the population of people with IDD and mental health needs as well.
So what's on the table is basically designed to increase access to both of those. So the CHIRP waiver has been really underutilized because it's been limited to children who were in the care of the child welfare department in the foster care system. And so the changes that are being discussed would eliminate that requirement so that parents would not have to give up the custody of their child to receive treatment. And that has been really one of the only sources that would pay for residential treatment for children that have IDD. So we hope to make that more accessible, even though we want long-term for children to be living with families in the community. We know that those intensive services must be able to be accessed when they are needed. And then similarly with the Child Mental Health Treatment Act, there's work on trying to expand access and increase the ability of that to pay for some intensive community-based services and make that more accessible as well. Okay.
Yeah, Christiana?
Yeah, I would just add that that's absolutely right.
Just because we're taping.
Historically has run out of funding halfway through the year. And access is absolutely important. One of the things with the Child Mental Health Treatment Act is they've asked for more funding so that they're not running into this, we're out. So that's just one other component.
Thank you.
Did you want to add anything else about the chart? Okay. So we want to make sure that we have a chance for some discussion and asking some questions. And we also have some that are coming in online. Oh, I don't need that. Here, you can take that. I had it in my hand. I figured I should use it. So one last question before we open it up, and then we'll pull the questions that are coming in online as well as from the live site here. So we've been working on issues, as we've been talking about, related to sort of some of the workforce challenges, systemic challenges in serving children, youth, adults with intellectual developmental disabilities and mental health needs. We're still hearing about some very real barriers to access to care, accessibility, appropriateness of care. So I want to ask each one of you, you have to just pick one thing. Each one of you, what is one solution that you'd like to see? And a brief explanation of how we might be able to get there as a state. And if you don't have that one solution, Carol, I might let you do two solutions, but keep them short.
Sorry. Well, this is Carol. What I'm seeing in the community currently, and I don't see everybody. It's certainly not as broad as you guys see, because I only get the people who are in big trouble. But I think if we had access to these therapeutic respite homes that were theoretically supposed to be available through the crisis the DHS crisis intervention thing, but aren't, they're just not available. So like the story you told earlier, and I'm pointing to the woman from Arc of Aurora who talked about the mom who can't get, they're looking for out-of-state placement. If we had those sort of therapeutic centers where, like Louisa was talking about, that people could go to for even a couple of days a week just to get stabilized, or for several months if that's what it required. Every huge advocacy case that I have around this dual diagnosis stuff is I got to get him out of the house for a while. I've got to stabilize this situation. I think CHIRP will give us we will build a money thing once we get that figured out. But I think we need to have the therapeutic respite availability throughout the state that can be short-term, but I'm talking short-term being months. I guess that's my biggest wish on the wish list.
Respite. Thank you.
And of course, it is hard to pick one thing because there's so many layers and these things are so interwoven. But I think that from my perspective, since you addressed respite, I think from my perspective, what I would like to see is for our state Medicaid system, our regional accountability entities, and I like that they're called accountability entities, because I think there's an accountability element in this that has to do with contractual agreements that mandate that there be specialization in this area so that we can better utilize the resources. I don't think we have to develop new systems. I think that we need to enhance the systems that we have to be specialists in this population so that we can do good preventative care. I'm really vested in serving the youth in this population because I believe that that's an investment in the spirit of early intervention that helps save money for our state and for Medicaid for years down the road in the lifespan of the individuals we're serving. And if we can find a way, I'm kind of past it's the right thing to do because I haven't seen that change our system. I think that it has to be financially incentivized. I think there has to be contractual mandates. I think there has to be accountability around making sure that we're creating specialization on the local level with community mental health centers. If they're good at adapting and they're knowledgeable and they're culturally competent with this population, not only will they provide specialized treatment, but they'll also interface with the developmental disability system. They'll know who their occupational therapist is they need to refer to. They'll know who their speech language therapist. They will understand the culture as well as the systems related to our individuals. And there has to be some sort of financial mandate in order for community mental health centers to be reimbursed adequately in order to serve the population.
Thanks. Ashley.
Okay, so it's really hard
Your
to
one
pick
wish.
one thing. And I think given the context of our system, there's all those issues. But I also think that there are a number of providers who I have spoken with and have been in focus groups with who have expressed that they really do want to better serve the population of individuals with IDD and mental health who feel like they don't have the skills or expertise. And so I think we need to offer as a state more accessible professional development, especially those that emphasize problem-based learning for mental health professionals so that they can, do things remotely and online and be able to access experts. We have had some success in that sort of different realm with a consultation group as well for trauma-informed care that offers free consultation to any provider across systems, whether it's a school or child welfare or mental health or whomever. And I think having that sort of infrastructure where when a mental health professional is stuck and they don't know what to do with an individual with IDD, that there is an easily accessible, free, and widely publicized group of experts that they can get advice from. And whether we use various forms of technology or whatever to do that via video conferencing, I think we have to put that infrastructure in place so that the state is offering the expertise to anyone who needs it, regardless of what system or what payer source or whatever. That expert consultation needs to be there and the professional development needs to be there and it needs to be easily accessible.
And I hear a lot of overlap in what was just said, that, it's not just having trained people, but it's having a dedicated, intentional group of people to serve a particular population that has the expertise to do that.
want to go on the record saying that if we get that established, I'll be the first one to participate in that consultation group.
Okay, you first heard it here. When this happens over the next 2 years, you first heard it here. So we do have a couple of questions, I think, that came in from people who are participating via the web. So maybe we can do those first and then open it up for some discussion. So do you want me to read through these? Or do you... Okay, I can do that. I have them here, but I'm not going to. So a question came in from Lisa Franklin, and she's asking, for the panel, I have often heard in meetings that the mental health centers, BHOs, don't have personnel or enough personnel that are trained to work with children and adults with IDD. Since agencies are receiving capitated payments for these clients, what do you see as the obligation of these systems to provide for training and expertise for this population? Not just being willing to enroll providers who have expertise, but actually increasing the capacity of the system to provide support for people with IDD. And I think that touches on what your one wish was, but does anybody sort of have a thought or a response to Lisa on that? Is it on?
Okay. So I think part of that is around accountability, that we have to ensure that our stakeholders are holding the RAIs accountable, and now the system holding the BHOs accountable, so that when people don't get the services they need, that is being pushed back up to the BHO or to the RAI and then to HCPF if they're not getting what they need. And I think that has been certainly not an ideal system, right, to put the burden on the individual who's seeking the service to make sure that they complain if they don't get it. But unfortunately, that's one of the only accountability mechanisms that we have in our system. So I think generally we need an increase in accountability. And one way that individuals and advocacy groups can do that is by ensuring that if a person needs a service, and whether the service is outright denied or the service isn't appropriate for the individual, that they are taking that up, that they need to hold the BHOs, they need to hold the RAIs accountable for that. And eventually, if it has to go all the way up to healthcare policy and financing, it has to. But we need to ensure that there's accountability, that we don't basically just, because if someone seeks service at a community mental health center and they don't get what they need, the BHO or the RAI doesn't even know necessarily that they didn't get what they need, right? And so you kind of have to push that further up the chain.
So it's kind of a consumer education issue in some ways, and
it is
making sure that consumers, people who are receiving services or not receiving services are empowered with the information they need and how to do that.
Right, and I think that's true of advocacy groups and others who may be referring individuals for services. So if schools or child welfare departments or advocacy groups or other community agencies are referring individuals, they can perhaps play a role in ensuring, that kind of consumer education piece and assisting with making sure that if the service is not available, that's kind of getting pushed up to the RAIs.
And I totally agree completely. I think just one little, I'm pretty pragmatic about these things. So it's one little pragmatic addition I would say to that is that, when community mental health centers or folks in the BHOs, they have a genuine interest or a genuine desire to develop these sorts of specialties. It comes down to individuals. It comes down to people. And it comes down to designating positions and programs for the specialization. Training is expensive, and it needs to be utilized in a way that's successful. You can't train an entire organization on this specialization, but you can train an individual who has some cultural competency. I've been hiring clinicians to specialize in this area for over 20 years, and most of them have had a family member with intellectual or developmental disability, or they worked as a direct service provider in a group home, or they have that sort of familiarity with the population, and so they have a willingness to work with the population. You have to designate individual positions in order to serve this population. And when those people leave because of turnover, you refill it. You designate those positions. And that's where I think the rubber meets the road when it comes to building capacity and competency for that mental health system.
Thank you for that. We have one more question from the web, and then we'll take questions here. So the next question was from Jermaine. I have families who are either receiving behavioral health services through EPSDT or mental health services through a BHO. With the change from BHOs to RAIs, will families be able to access both? Anybody? And maybe there needs to be some clarification about, I mean, EPSDT essentially is the Medicaid benefit for children. So EPSDT isn't a separate program, it's the Medicaid benefit for children. So I don't know if that provides clarification, but.
Well, they should be able to do that. And I just want to say that, you know, one of the key components is that, you know, because coming from a mental health system who serves many people who receive behavioral services through EPSDT, you got to have that care coordination piece. We see that as our responsibility, is that we're not just, you know, providing mental health services and therapy. We're also doing the care coordination so that we're integrating the care. They're paid for by two different entities, but the team that works with the individual can still work collaboratively to integrate care.
Yeah, and EPSDT is not a benefit. It is a federal mandate that requires any state who does Medicaid, who gets money from the feds, to do a wide range of services. And one of the wide ranges of services is the T for treatment. And we in Colorado have chosen to put behavioral services under EPSDT for reasons that are not obvious to me. But Jermaine, there is no reason that a child who needs mental health treatment and also needs behavioral services shouldn't be able to get both. Right now, not later under the RAIs, right now, they should be able to get both, because EPSDT in general says that if it's medically necessary, the child should get it. Period. End of story.
I think she passed it to Ash.
Just a little bit, and I think the behavioral services that will not be managed by the RAIs will definitely still be accessible. And I'm not certain on the reason, but I think it may have to do with actually just not wanting those to be capitated. But those will still be accessible, as will traditional mental health services and psychiatry and everything else through the RAIs. So they will both still be accessible, and there will be some burden on the RAIs to make sure that there's care coordination, but I don't know that all the details have been worked out about what that will look like.
I think something to think about is around the care coordination, that it's not going to just be care coordination internal to the RAIS services, but it's care coordination with other benefits that a child or adult might have. Because the care coordination has to be sort of outside of the mental health services. For instance, if a provider external to the RAI is providing mental health or providing behavioral health services.
I think there's going to be numerous models of care coordination used, and so I think that might depend on which type of care coordination for which population. So, for example, you know, they're looking at you know, high fidelity wraparound for this population, and then for adults that have chronic disease, you know, another type of different systems. And so I think that might vary depending on which model of care coordination for which population.
So I think that's all we had from coming in from online. So do you all have comments, questions? And I can run around with the...
Hi, I just wondered, Ashley, I think this is probably a question for you. Do you know if there are, for lack of a better term, customer care avenues for the BHOs and the RAIs that are currently in place, or how do you suggest that families try to communicate that they're not getting their needs met?
And, you know, I wonder if I don't know if you can point that towards you. Yeah.
Okay, can you hear? Yeah. So currently with the BHOs, there's a number that you can call that's on the HCPF website. And you can actually request a care coordinator through the BHO. But that is the sort of avenue, is like you just called them. And I don't know what the system will be for the raise yet, but I assume it will probably be similar, that there will be sort of a customer care number for each ray that you call, and that you can also request care coordination from the rays as well.
Other questions, comments? It's all clear and you know how to fix it. Is that what I'm hearing? So just a follow up on that, would you say that that's sort of the equivalent of an ombuds initiative? I mean, is there anything that sort of serves as sort of an ombuds program around mental health?
That would be the closest thing. That would be the closest thing that I'm aware of. I'm not sure whether maybe anyone else in the audience knows whether there's something else. There is a position at HCPF that oversees, behavioral health. And so I think if things like really rose to the level that the BHO or the RAY was continuously not meeting a need, there may be, a person to contact at HCPF. But I think a lot of it is that what unfortunately happens when individuals don't get their needs met, they don't have the time or they don't know that they can. And so they don't push it up further and further and further. I sort of liken it to fighting with my insurance company. It's like nothing fills my stomach with a sense of dread other than having to call my insurance company and fight with them about paying for something. And so when it's so difficult, I think people often, and of course, people with complex health challenges just don't always have the time to pursue every service that they, needed that they didn't receive. But unfortunately, I think that might be sort of the best solution, is that if people in mass report to the DHOs and the RAYs that they need a specific service or a specialized service, then it becomes, in their interest. They know that it's needed and therefore they're more likely to provide it.
So it sounds like for all of the advocacy organizations in here, yes, I'm looking at you, Anna, I'm looking at you guys. It sounds like maybe that's sort of a training event that might happen, is that people know what the resources are for. So pulling someone in or something. But it sounds like that is sort of an advocacy need, is a consumer education, sort of individual education on what to do, what the system is supposed to look like, how it's supposed to work, and what to do if that's not how it's working within the mental health system.
And I also want to add to that if the service that a person needs is not available from the mental health center, then it's sort of the burden is on the BHO or will be on the RAY to find another provider in the network or do an out-of-network contract for an individual. And so we shouldn't sort of believe that just because the community mental health center doesn't have a certain service, that means it's not accessible to people who are on Medicaid. If the service is medically necessary, the BHOs or in the future the RAYs have to provide it, and so you kind of have to go up the chain until you find it. But if the BHOs or the RAYs don't know that you need it because you only talk to the mental health center, then the BHOs or the RAYs don't even know. So I think that's a big problem that we've experienced. People accept that's not available at the mental health center as that's not available within the Medicaid network, but that's not what that means.
So there's another step that can be taken.
And every community mental health center also has a client representative. And so if you interface at that local level, don't feel that you get what you need. That's an easy place to start, is with a client representative at the community mental health center.
So if somebody calls the community mental health center, they would ask for, I would like to speak to the client representative.
Sorry, this may be a little far afield and maybe a little bit in the weeds, but with the Affordable Care Act, mental health became a necessary sort of service, and there's been lots of attempts at limiting what's available through the ACA, through the different repeal sort of efforts. Do you have a sense of, if that was to come off the list of essential services, how that will affect the rate, BHO sort of moving forward?
I don't think it would have any impact on Medicaid patients. I think that would largely affect patients that have private insurance, but I would not anticipate that would affect patients who receive Medicaid. because that has been covered for many, many years prior to the Affordable Care Act under Medicaid. So I certainly see that it would potentially affect the sort of availability of those mental health professionals within the state. It could unfortunately even make them, not unfortunately, but have one of those sort of effects of like making them more accessible to people with Medicaid if more people with private insurance aren't able to have access. But I definitely don't think that there would be an impact to those receiving Medicaid. It could even potentially drive more providers into the Medicaid network if fewer insurance policies. But most insurance policies, even prior to the ACA, did cover mental health, even before the establishment of the essential benefits. It was mostly small policies offered by very small employers that did not have mental health as an essential benefit. And so I don't really anticipate that it would cause a major shift, even if that were to be repealed, because certainly Medicaid and most insurance companies would likely still cover mental health.
Time for one more question and then we'll wrap up. Or thought?
I think that's an interesting thing for us to take a look at, Christiana. This is Carol, because mental health parity, I mean, it was in the ACA that mental health was an essential benefit. That it needed to be covered by all commercial plans. But mental health parity, from my understanding, has been partially implemented, if not, so basically mental health parity is that if you have, depression or diabetes, it doesn't matter. You should be able to get adequate treatment for either one of those things. But if you look, for a lot of people, it's the copays are like twice as high, or those kinds of things reduce access. And if we're from Brian's perspective around the preventative stuff, which is what we'd all like to see, it's just so much more humane to keep people stable than to have to go to emergency rooms and all police departments and be cuffed and all that kind of stuff. I think it's an important thing for us to keep an eye on as we do this work.
So, I think the bottom line is that whether it's a person with intellectual and developmental disabilities or not, it's our right to get mental health care. And I think regardless of sort of which other service systems might be supporting an individual, a child, a youth, an adult, people have a human right to get mental health care through parity, through Medicaid, through sort of whatever mechanism or whatever insurance plan they have. It shouldn't be so different and so difficult because somebody happens to have an intellectual or developmental disability. So I'm thinking back to Cristiano's slides when sort of you had a number of the ones in there that were referring to kind of some civil rights policy issues that were coming up. And I think of it as a rights issue, that because somebody is sort of part of a certain population should not mean that they have different access to the kind of care, the kind of treatment, the kind of prevention that I would have access to or somebody else might have access to. So I want to thank you all very much for what turned out to be a little bit longer, but I think we had some great discussion. You guys, I think, provided some excellent information about not only what some of the challenges are, but how we can move forward. So I think there are even a couple of next steps that can be taken as you walk out of this room. If there's a RAY meeting and there's the opportunity for public input, you all have the ability to be there. And putting people in touch with, what's the name of the person at the mental health centers? The client representative at the mental health centers if there are some challenges in accessing care. So a number of sort of immediate things that hopefully are pieces of information that are helpful to you as you walk out the door today. So thank you very much. And I don't know if somebody's gonna be wrapping up the meeting. Is that me? Oh, I thought maybe I could pass it on to Carol now. So just finishing up the meeting, we're done.
Oh, thank
So hopefully there were some little gems, if not everything from the meeting that you're able to sort of take and move forward with. And we really appreciate the time that you've spent with us this morning to not only hear a little bit about some things that are going on in our state, but some of the momentum that we need to continue to maintain in order to get some of these issues addressed. So thank you all very much, and looking forward to seeing you at the next CANDO meeting, hopefully. Thanks.